Hello, my name is Natalie Bulger, and I will be presenting on the number of advanced airway attempts and outcomes following out-of-hospital cardiac arrest. I don't have any disclaimers. I am currently the research coordinator for Seattle Medic 1. This study was approved by the University of Washington IRB. This study focuses on advanced airway management. Current literature states that the optimal strategy for advanced airway placement is one that minimizes interruptions to chest compressions and decreases the amount of time spent in apnea. Some EMS agencies have transitioned from endotracheal tube intubation to supraglottic airways. However, endotracheal tube remains the standard because it achieves a higher order of airway protection and assures directed ventilation and oxygenation. In order to optimize all the necessary components, it is important to understand the process of intubation. It has been shown that the need for multiple intubation attempts is associated with adverse outcomes among RSI patients. However, the relationship between intubation attempts and patient-centered clinical outcomes in out-of-hospital cardiac arrest is limited. We sought to investigate whether the number of laryngoscopic attempts to place an endotracheal tube was associated with clinical outcomes following out-of-hospital cardiac arrest. We hypothesized that the number of attempts would be associated with a lower likelihood of favorable neurologic status at discharge. This was a retrospective observational study for non-traumatic out-of-hospital cardiac arrest patients treated by Seattle Fire between January 1st, 2015 and June 30th, 2019. The Seattle Fire Department is the primary sole provider of 911 response in the city of Seattle, operating in a tiered response model. Paramedics employ direct laryngoscopy for endotracheal tube intubation as the primary advanced airway, following a common airway management algorithm. Additional airway adjuncts include IGEL, cricothyrotomy, and BVM. In resuscitation, paramedics prioritize intubation and IV placement upon arrival, as the first-tier BLS responders are already providing chest compressions and rescue breathing. Paramedics are trained to confirm endotracheal tube placement using capnography as soon as possible upon completion of intubation. We use prospectively collected out-of-hospital cardiac arrest and advanced airway registries. The Quality Improvement Research Team in the Seattle Medic 1 office review individual case reports, organizational registries, and the audio recording on the LifePack devices to determine the timestamp of successful endotracheal tube placement. The Seattle Out-of-Hospital Cardiac Arrest Registry uses dispatch, EMS, defibrillator, and hospital records to ascertain information. The defibrillator records real-time audio, continuous ECG, continuous and tidal peripheral oxygen saturation, and continuous transthoracic impedance. The Advanced Airway Registry is an electronic survey following any patient encounter that involves any attempted advanced airway procedure. The paramedic who managed the airway completes a web-based form, which is then compared to the audio recording by a trained data abstractor to verify airway placement. The time of endotracheal tube placement was defined as the time of the first ventilation via the endotracheal tube, determined by audio recording of provider verbalization or by production of a capnography waveform by inline end tidal CO2. We use multivariable logistic regression to evaluate the independent association between outcome and the number of laryngoscopic attempts, using intubation on the first attempt as the referent group. In the multivariable model, the odds ratio was adjusted for age, sex, witness status, bystander CPR, initial rhythm, and the time interval of 911 call to ALS arrival. Our primary outcome was survival with cerebral performance category of 1 or 2. Secondary outcomes include CPC 3 or 4, survival to hospital admission, and ROSC. The final model used an ordered single variable to classify intubation attempt and determine the odds of favorable survival with each successive intubation attempt. We a priori assess the relationship between intubation attempt and outcome according to rhythm, shockable, and non-shockable by the inclusion of an interaction term between intubation attempt and initial rhythm. We elected to exclude any patients who arrested after arrival, had a pulse upon arrival, received BLS only or no ACLS care, had a valid DNR present, received ACLS treatment by a non-SFD agency, and those who received an intubation post their first ROSC. Because we utilized a prospectively collected advanced airway registry completed by paramedics, we had a few patients who were missing a completed intubation form. Therefore, they did not get included in the analysis of number of attempts, but were included in the demographics. Here are a handful of our patient demographics and timing results. Patient age and bystander CPR percentage remain consistent across all number of intubation attempts. Other process measures of advanced care, such as IVIO access and or drug treatment, did not differ according to intubation attempt. This figure demonstrates the final status of the patient, stratified between blue for survived and gray for died. They were then broken up by the number of intubation attempts as seen on the y-axis, compared to the time from ALS arrival to successful placement of an endotracheal device as seen by the x-axis in minutes. ALS arrival was determined in a hierarchical fashion. This approach prioritized audio confirmation from the BLS defibrillator, followed by ALS monitor defibrillator turn-on time, and finally the timestamp from the computer-aided dispatch record. As can be seen on the figure, the median time for intubation from ALS arrival to intubation increased as the number of attempts increased. In a multivariable adjusted model, favorable neurologic outcome decreased by 57% for every subsequent intubation attempt. Results were similar for our secondary outcomes. The adjusted odds ratio decreased with each successive intubation attempt for hospital discharge, hospital admission, and ROSC. All of our outcomes were considered statistically significant as all confidence intervals did not cross 1. All of these trends held true when comparing AOR across shockable and non-shockable cohorts as demonstrated by the table. The model could not be run for the non-VF good neurologic function cohort because the number of attempts perfectly predicted neurological outcome. That is, only those with one attempt had good neuro outcomes. We observed a dose-dependent relationship between increasing intubation attempts and lower likelihood of functional neurologic survival, and this relationship carried through for all other intermediate outcomes. Repeated intubation attempts may have adverse effects such as an interruption in gas exchange, increased aspiration risk, reduced circulation, and/or a marker of a difficult airway. There is a complex relationship of time-dependent variables. However, historically, first-pass success rates in cardiac arrest patients have been lower than those in RSI patients. EMS agencies should look into their larger airway management portfolio to promote proficiency and increase first-pass success, perhaps by increasing frequency or quality of training and/or introducing the use of a gum elastic bougie. A previous study conducted by Latimer et al. Found that the use of a gum elastic bougie increased first-pass success by 9% among patients in cardiac arrest. Previously reported first-pass success rates include 69.4% from the Airway True and 51.6% reported by Wang et al. This study reports a first-pass success rate of 63.3%, which is similar to the first-pass success rate of 62.2% at a system level when considering patients during the same time frame who were intubated during cardiac arrest. Although we believe this study is valuable and compelling, we do appreciate that the results were derived from a retrospective data collected from a single large urban EMS system. This study was also utilizing registries populated without specific knowledge of current study aims and does not address causality. However, the data does get compared to the audio recording for airway verification by a trained data abstractor to counteract any limitations in the advanced airway registry. Ultimately, this limitation should be considered, but this assessment is unique in the literature on the topic of the airway interventions after out-of-hospital cardiac arrest because it harnesses audio and monitor downloads to accurately describe the granularity of time-specific interventions. Our conclusions are consistent with our original hypothesis that an increasing number of intubation attempts is associated with lower odds of favorable neurologic status at discharge. These findings advance the understanding that operational characteristics of intubation are associated with prognosis and in turn likely affect the comparative effectiveness of endotracheal tube intubation relative to other airway management strategies. As stakeholders and EMS systems, attention should be directed to the number of intubation attempts and potential clinical consequences of repeated attempts and strategies to promote proficiency. Thank you so much for your time, and I will now take any questions, which I guess is not happening in this virtual format, so thank you for your time. Here is a QR code to my references.